돼요? 네, 이제 읽어 간다고. 죄송하다고 얘기하고 I'm sorry for the confusion, and now we are discussing about the ECG, and we'll keep progress. And can you briefly summarize what we discussed? Actually, this is the first page of the slide, and we're talking about this narrow, wide QRS complex tachycardia. There were thoughts whether this is SVT with aberrancy or VT. This ECG shows the predominant R wave in AVR width, and maybe the P wave shows some AV dissociation. So it could be VT, but also the AV dissociation is not that sure. So also could be SVT. And I will go to the next slide. The patient in the ER, the rhythm self-terminated and changed to this rhythm. And I think this rhythm is also interesting. Okay, this time let's start from here. We can see the QS as the elevation and in 1, 2, 3, 4. Also, if you are show as the elevation, Georgia. It's complex rhythm. To aggregate the equation, we want to merge this elevation. Mom. Okay, in the rhythm strip, how many different kind of QRS can you see? Many. Many. Are they regular or irregular? Regular. Regular. Wide curves or narrow curves? Some of them is wide, some of them narrow, right? Yeah. And is there any P and QRS relationship? Rhythm strip. Rhythm 2. I don't think so. Some Which one?
This has a P which is not PRing about.
It is too short to be conducted, right?
Yes.
Okay.
There's this which is much longer.
Yeah. And
there's this which is shorter. I think this is probably, I'm not sure if it's just part of the T wave or it's a TP fusion. There's this, which is also very long.
Okay. Next one.
There's this, which is occurring within the T wave. So this is, yeah, so there's this one, either a retrograde P wave from this complex or a dissociated P wave. And this is also too close. If anything, this is too close. This is also
even though the ppm is not regular and morphology sometimes looks like a retrograde P, but the PQRST relationship is not regular, right?
Yes.
So it's real AB dissociation, as Kofi pointed out in the previous ECG. And anybody can differentiate narrow QRS complex and wide QRS complex? Why are they different? And is there some possibility that P wave conducted QRS or not? Junyoung, your turn.
We consider many different morphology of QRS. The in the thoracic wide QRS complex looks like similar with the previously we saw. The PDC.
Similar but different, right? Okay. Okay, Dr. Hanji Park is shaking his head.
These four different pairs morphology. And the one that this one has the possibility of AV conduction, but when I compare all others, I don't see any regularity because if this one is conducted, some might should have the same should here in this side, but I think there's no relation. So yeah, this is just AV dissociation, and the PP interval is not regular as well. So I think there is no AV association and four different white pairs complex.
What is cause of AV dissociation? Is it due to ventricular rhythm predominant or Hoplock? If the PP interval is shorter than QRS interval, RR interval, probably is Hoplock, right? But PP interval is longer than the RR interval. It could be the ventricular rhythm. Am I right?
Yeah, but the PP interval is not regular.
Yeah, that's right.
There is no more V than A, so I think it is not a conflict. But yeah, isorhythmic
not isorhythmic, but not complete AV block, but AV dissociation. Okay.
This is very complex rhythm, but if you look the bird's eye view, can you see any the group beating pattern? Okay, example. Da 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 da. Even though the shape is a little different, da da. I don't know. Da, da, da. Okay, because these wide currents, the complex is the break down the cardiac ballet. But I see some pattern of rhythm, and the current morphology is different, but some of them could be fusion with another complex. In which case, can you see this kind of cardiac ballet? Probably all those are coming from the ventricular rhythm, and the chorus is relatively narrow. In which situation? Coffee. Okay. So this is a relatively narrow ventricular rhythm, right? And shows some pattern,
Yes.
right? And can you suspect in which situation can you this kind of regularly irregular rhythm?
For patients who have like an intermittent AD conduction block, could have this, and the one that seems to break the rhythm looks a bit broader, which could be a fusion between something coming from up and a PVC. Yes, I'm thinking that could account for the change in the morphology.
And if you look at the B1, there's alternate LBBB and RBB pattern. So all those are coming from the conduction system. That's why the chorus is narrow and there's some regularity. And it could be there delayed after the deployment triggered activity. Any other comments?
I suspected this could be the conduction of P wave and QRS and P wave and QRS. And I think this rhythm seems similar in here. And maybe this could be a long PR interval and conducted. And
very long PR.
Yeah.
Yeah. Did you measure this interval and this interval? I think it looks longer. Later one. Okay, please let us know the whole story because it is almost time to international conference.
So the patient was 84 years old man, and he came to the ER for no response, and he had the bystander CPR, and the initial rhythm was VPIP, and he had 3 times of cardioversion, and the ROSC when he came to ER. He had history of severe AS with bioprosthetic AVR about 5 years ago in other hospital, and he also had the obstructive ACMP. It revealed later that the maximal thickness was 21 millimeter, and the peak pressure gradient of LVOT was about 98 millimeter Hg. And he also had the AFib and sick sinus syndrome. And this was the VPIP rhythm. And he had 3 times of cardioversion. And he had cardiomegaly with left ventricular hypertrophy. And this is our T report. And the bioprosthetic AV was functioning well. And here said the enlarged array, but the ejection fraction was preserved. he had the obstructive ACMP with the peak gradient was about 100 even in the resting status. And he also had the relaxation abnormality of elbow feeling pattern. And this is the same day of the earlier ECG, and this is the rate of about 60. And I also suspected the prolonged PR in here. And that's why I suspected that the earlier ECG also had the prolonged PR interval. And after this 26th of April, the patient had wide QRS tachycardia about rate of 100 per minute, and maybe could be aberrancy. And he also developed the AP pattern. So this is the end of my slide. So I was really interested in this case because he shows too many QRS complexes, and I'm not sure about some of the teach pattern. That's why I choose this case today.
Okay, back to the first slide. No. Keep the last one. No, the last one. And comparing the first wide curve rhythm, how does it differ from the first slide, the last slide?
So this one is irregular.
This
The
is
first-
ACM.
Yes, this is AFib. And in the first slide, V1 and V2 looked a bit narrower. So this one is a clear LBBB pattern in V1 and V2. But yes, with AFib, very irregular compared to the first one.
Can you show us the first one? Very first one. Okay. So precordial transition and access a little different, but generally same. But I'm concerning the AVR R wave is so predominant in CG. So still I cannot differentiate clearly from the AT ever C versus VT. Okay. But if I can clearly see the VA dissociation, we can say definitely is VT. The axis is pretty similar to the atrial fibrillation. Okay. So this is HCM patient, and probably we saw multiple ECG with Hoplow, very difficult ECG, but we need to differentiate based on the ECG. It's not complete, but if this patient has ICD, probably we can. Okay. Yep. All right. Thank you very much. Dr. Tong Kim, are you there?
Good potential in the ablation, and then in the near the his recurring catheter in the septum area, I find some relatively earlier potential, and AV looks quite near, and then we start, but it was too close with the his catheter, and then we start 15 and then finally increasing the 20 watts, but there was no significant change, no junction, and no any change of the potential. And then we try to find another good point several times according to the ablation signal. And we try and near the septum area. And then as I found the A and V is quite nearer, and then it looks much closer, but there was no significant change. No any junction and no any sequence change was shown. So I think so, but the problem was that I was not very confident, and then I was worrying about the AV block, so I cannot deliver very long time and very high power near there. So we try some good point, and then with the low energy and then very short time, I hope to some sequence change and I want to deliver some more time. However, uh, in the 16th ablation, there was some the catatonitis or junctional rhythm, but I was worrying and then we stopped and we tried to find again. So before we make the V pacing before the ablation 17, and then intermittent capture. But when we see the captured beat, ablation distal looks very fragment signal. So I think it's maybe the accessory pathway potential. So we ablate here, and during the mapping, we find some significant His signal in the ablation distal. So that I think the His distal, at first time I realized that we can A and V is quite near, so we cannot find clear His, but realized that it could be not very exact point of the His. So but when I was during the time, it was already 6 hours passed, and then I tried to change some his potential, but cannot find the discrete potential here as well. And then we try to find some good potential and the mapping again and again, more than 8 hours, and then try to ablation with very low power and then very short duration firstly, but finally failed to check the sequence change of the potential. So I decided to give up because the I started around 10 a.m., but it was already 8 p.m. And then I was also exhausted, and then our the colleagues also could not find potential more. But I cannot find eliminate bypass track, and I can achieve the significant potential change. So after finishing still the delta Y is present. So after I fail, I reflect I review the EGM again, what I was missing. And then I realized that at the time I think, maybe I got the not very clear is potential, but after reviewing, I was misunderstood the A and V potential of the his. So when we make the straight pacing, firstly, when I think this is A and then this could be a V, but during the pacing, this two signal is totally disappear. That means it's one of them are not A. And then during V pacing, similarly, I think one of them are V and one of them are A, but during the block, A block, so two signal is quietly same. So that means both of them are V. So my assumption was totally wrong because I think and V earliest VA the lead is his distal, and then that's one of my assumption that the septal bypass track, but it was totally wrong. And then another potential when I see some the fusion beat with the PVC, the second beat and third beat, his distal and his proximal uh, potential was similar. That means not one of them are not A. That means both of them are V signal. So that is one of the important theory of mine. Septal bypass track was so that looks quite near in the A and V, but I was totally wrong. And when I review again in the EGM, surface EKG and 12 lead EKG so it was a little bit different when I review again according to the transition zone. And then I think not only the septal area, but we need to consider some anteroseptal and then anterior area as well. When we see, according to this article, they mention about the anterior and anteroseptal, uh, the transition, and then our case was when we say anteroseptal, our transition zone is relatively slower than anteroseptal area and mesoceptal area. So I think we needed to check about the anteroseptal or free wall area as well. And then in the October this year, Dr. Huang visited the Cambodia, and then I think it would be much better to do the case with him together. So this is baseline delta, similar with the previous one. And then catheter position was we can put the deca catheter in the RA, and then RV, and then his catheter together. And then tachycardia was induced during the catheter positioning. And then this is the EGM from the tachycardia. So pattern is, so this time we changed some the catheter position, but anyway, EGM pattern was relatively similar. And then tachycardia was terminated with some catheter-induced PVC. And this is the when the tachycardia was terminated. There was some the multiple the premature beat and finally terminated for tachycardia. And we also the tachycardia previous compared with previous time, tachycardia was relatively induced much more better, and then we went to the VA simultaneous pacing and it's terminated. And this is the baseline EGM. And compared with the last the first case, we can see clear proximal P his potential here, and then we distinguish A and V potential much clear. And then Dr. Huang asked that we need to firstly put the RV catheter in a different position first. So we put the LV catheter relatively septal side, and then thereafter we put the RV catheter relatively freeward side. When we compare the onset of the RV signal, it is relatively slower later. So it's about his potential. But when we put the catheter to the RV free wall, the RV signal was earlier than the septal side, and then earlier than his potential, and around the onset of the delta wave QRS complex. So that the bypass track was maybe not the septal side, but relatively the freer side of the anterior area. And we make the V pacing, but we can see in the baseline, this was quite V. We cannot identify distinguish the VA in his catheter because V was too big, and then we cannot see clear the small tiny A potential in here, and then we cannot say that his distal was the earliest A potential. And then when we try to make the V overdrive pacing to check about the post-pacing interval, but when we pacing stopped, and then tachycardia was terminated, but several the premature beat was came, and then induction of tachycardia again. Any additional the finding during the second EP study, so early state potential we cannot identify due to earliest V and big V, and cannot find significant A potential in his. And then during the position of the RV catheter in different side during the sinus rhythm, bypass wall excessive pathway conduction is faster than septal one. And during tachycardia and AV, simultaneous capture was terminated the tachycardia. And this time it was easily induced with catheter and terminated by the multiple premature beat. So we put the ablation catheter again, and then this is the V pacing with the ablation catheter. We put the catheter relatively the freeward side in anterior freeward side, and then we can find some potential in relatively wide VA interval is relatively narrower in the anterior septal area, and then we make some ablation in so compare with the previous ablation when we can see the clear his potential, and then it was really bit earlier than his in the merging some potential there. However, there is no significant signal change was shown when we deliver. This time we give the 30 watts and then giving the more longer time of ablation, but no signal change was shown. And then we change the location and then we find some signal for that. And we go relatively more anterior side and then ablate and more, but still no any change. And during the tachycardia, some the pretty much maybe APC near his potential induce some tachycardia, but when we see here the last some A signal and then there are very long uh, AH interval and then his potential and conduction. So I think uh, during the baseline study we cannot find significant evidence for the slow pathway, but I think we need to also consider here as slow pathway as well. Anyway, we focus on the ablation near the earliest, according to the potential in the ablation. And again, and finally I failed, and then Dr. Wang came to help me. And more anterior side, freeware side with the potential, but no change. And from we try so many times, but no any change. We deliver more than 1 minute, but no change. So finally, we increasing the power to 40 and the 45, and then we put the long sheath and then make more curve and reach to the freeware side. And then during the 37th ablation, we deliver more than 30 seconds. And then we think, maybe also there that this side, but signal was changed around the 30 seconds. But within 10 seconds after ablation, it recurred again. And then we deliver additional burn in the relatively anterior area. And then during the ablation, for the 15 seconds, it was also changed the potential, and then the bypass access pathway was blocked. And then 15 minutes, we wait more and then recur again. So I think we are near the access pathway, but did not deliver some enough energy. And then we find some another potential, and then also around not blocked immediately, but 10 seconds, access pathway was blocked, and then we deliver around 2 minutes of the ablation with here. And then finally we make some booster ablation near the last ablation site, also more than 2 minutes. And thereafter, when we pick V pacing, there was a VA dissociation was noted, and then we wait more than 30 minutes, but no more VA conduction during the V pacing, and we finished the case. And we also make the A straight pacing, also A block cycle length was noted too. And I think we have some evidence of slow pathway. We make some A straight pacing, the extra stimulus showing there was some significant increasing of the interval. However, thereafter it was blocked, so we finished the case. This is the final EKG. And then this is the EKG followed during there was significant right bundle pattern. We did not I did not notify before the ablation. And then 1 month later, there was no recur thereafter. So my reflection point and wanted to get some advice was that second case, we cannot ablate extra pathway with usual power and duration of the ablation. So I want to know this was some and free wall, the oblique pathway or very deep accessory pathway, because even we give very strong power and very long duration, but still recur and again, and then we cannot reach the exact point, even we deliver energy more than 30 times.
Thank you, Dr. Isaac, for the fantastic presentation of a rather complex case. Well, may I just summarize that your case is on a 20-year-old with frequent palpitation, and can I just go? Can you just show back the first ECG that you have shown us? So I find that this ECG interesting once you have shown it, and also the initial ECG during the EGM. I just find there is some differences when you were doing atrial pacing compared to this ECG. So on this ECG, it seems that there is a bypass track. There is a initial positive R wave in V1. You have mentioned that it's sort of like an early transition, which we might think it's a more subtle. But when I noticed that when you were doing the EGM, over the atrial pacing, there seems to be a different QRS morphology, which sort of manifests that it could be that it is not fully pre-excited during the sinus rhythm, where it's fused with the normal QRS. And during atrial pacing, it seems to be a fully pre-excited one, which clearly shows a fully negative V1, and of course a broader pattern that could point us to sort of a right-sided anterior free wall kind of bypass track. And during the duodeca which you have placed, yeah, I find that when you did the high RA pacing, the RV distal signal is actually rather early compared to all the rest. I know that initially you were thinking that the RV the QRS the RV signal over the his could be earlier, but I thought the RV apex, you can see RVA is actually uh, to me is the earliest. So that could also point towards, a rather lateral free wall anterior kind of a right anterior wall of the accessory pathway rather than the Hessian one. But that I do understand that the sort of a field signal in the His is rather misleading in this case. And I think similarly, when you did the RV pacing, the dual 1920 was also early compared to the CSA, which also probably point towards the sort of the right anterior or right lateral bypass track in a way. Yeah, so that's my comment. But I'm wondering during the second procedure, during ablation, I noticed that you probably did use non-irrigated ablation catheter. Is there any limitation in terms of temperature that you were not able to get a deep enough lesion over the site with a field signal?
I'm sorry. So we use non-irrigated catheter, and then we have the irrigation catheter, but we think there is no very significantly increase of impedance and then the temperature, so we still continue with the non-irrigation catheter.
Right. Okay. Yeah. I find that it happens to me sometimes as well, that we got a nice signal, but even increasing the power, the ablation energy is limited somehow by the temperature and the impedance, like you have mentioned, that it was not able to deliver a good enough lesion there. So wondering whether if you could have changed to a irrigated catheter, that would actually deliver a good enough lesion to think the place which you have met, or even it's the signal looks quite fused there. Wondering if just a change of catheter would actually achieve the ablation success in this case. Yeah. Can I see the last ablation signal? Before the
Okay.
yeah, no, even
No,
before.
no. It's 41. Yeah, this would be
before the loss of the
Yeah,
delta.
this one.
Right, there's not sort of like far field, or maybe there's
Yeah,
already quite a
this
lot of
one.
ablation during that site, then there's a lot of edema over there, which
Yes.
could happen when you have ablated an area, probably not deep enough, and you are trying to reach a deeper area. So the signal over that site is edematous. So the signals are all, far field
Mhm.
and low amplitude. Yeah, can't really see a nice field signal there. Yeah. But all this ablation is around the same area, isn't it? Sort of like a tricuspid annulus, right?
Yeah, yeah.
12 o'clock.
Yes.
Yeah, yeah. Uh, okay. Just wondering, during the first case when you were doing the parahesian ablation over the hesian area,
Mhm.
were there any discussion with the patient regarding the risk of AV
Oh yeah,
block?
of course, of course, of course. And,
Yeah,
and we
because
did
I
not deliver very long
uh,
duration, just short duration. And then I also very worrying because yeah, it's a very limited resources here.
yeah,
Yeah,
I can
explain.
understand that. Yeah, it was a great effort, but yeah, I think it was a bit brave from you to ablate like what was the length? 8 hours for
Yeah,
the
yeah.
first procedure. That
That's
was very
yeah, yeah.
uh yeah, but I think that shows the pitfall of not getting a good his signal, and then it led to a sort of wrong misconception of the septal pathway,
Yeah.
where it could be more anterior. Yeah.
Mm.
Mm. Is there any difference between the first procedure where you could not get a nice hiss and the second procedure when you get a nice hiss? What
Uh,
have you done differently?
so usually we use some the quadric catheter without curve because we don't have much the the quadric catheter with the curve. But second case we use some the curve and then we can make the flexion and then we try to find much better potential, his potential. And the difference is that the catheter type. But first
Mhm.
time I did not realize that oh we need to change the catheter or not. So but second time we start with some good one first.
Understood. Yeah. But in some case, because I think your ablation catheter was already around the area of the his, I'm just wondering during the ablation in the first procedure, whether when you are moving the catheter around the his, have you managed to map, some sort of like a his signal during that site since it's deflectable uh,
Mm-hmm.
during the first
Ah,
procedure?
yes,
Because
yes, good one.
sometimes when
Yeah.
we are doing parahesian ablation, we would actually map it using our ablation catheter just to make sure we are, away from
Mm,
the his. So I'm just wondering,
mm,
when you are moving, if you see closely, you might be able to see some his signal or separate his signal.
mm,
It must be there because the second procedure you have seen it quite nicely. So I'm just
mm,
wondering, in the first case, if the catheter is around the vicinity, some of the time it could probably pass by the his, and probably it has been missed. Yeah,
mm, mm.
yeah, that's my comment. Thank you very much. Yeah.
Thank you so much.
Yeah, thank you. It's a great case, great learning points. So is there any comments from other professors that I
Hi, Dr. Owen, Dr. Chair, and now Korea. I enjoyed your presentation and discussion very much. It's a very tough case, and did you ablate over 6 hours in first trial? 9 hours?
Yes.
9 hours.
Uh, we start it at around 10:30 and we finish 8, but the total mapping time is around 8 hours.
Wow, I admire it. So even though the location of a bypass track is a very dangerous area, but you ablate and the mapping for long time. And I wonder the first Hisbonder location is exact location of potentially a insertional bypass thread. How do you think?
Uh, I also consider that one. So insertion and then the yeah that could be very long. But I cannot say that clearly because I did not put his catheter much clearly, and then some at least the A in the V pacing or ablation was not guaranteed. So we can I think I cannot say that near
But
is
in
near
your
the his excision.
electron, his bundle potential looks like the accessory pathway potential A insertion site, even though you don't have the V local V, right?
Yes.
So if so, you ablate the around the accessory pathway, except for the accessory pathway location in the first time. Am I right?
But my assumption is that when we see this EGM, when I assume that this both A potential looks not showing in the AV block, so both of them could be some the V potential. So that was my reflection after the few days later when I reviewed the EGM.
Mhm.
So that we cannot clearly say that the insertion was parahesian. So we need to find some the much more better potential near his or some the free wall side.
Yeah, that's what I want to say. The ECG, surface ECG suggests the location of bypass plug is anteroseptal or anterolateral area, right?
Uh-huh. Yes, yes.
But if the his bundle potential shows AV merge, even though it was misinterpreted, then it is mid-septal bypass tract, and those ECG usually shows negative delta and lead 3, right? So
Yes,
you
yes.
saw the discrepancy between the surface ECG and the intracardiac electron. We need to look for the right position of his bundle potential first.
Yes, yes, yes.
And also, another tip is you use the duodecapolar catheter first time.
Yes.
The duodecapolar catheter has a multiple the electrode. You can map the right agent. So you don't need to the CS electron deep inside. Pull back a little bit and clockwise rotation, and you
Yes.
can map there even the anterior the tricuspid annulus. Because the young patient has their D-shaped tricuspid annulus, unless the patient has RV failure, you can manipulate due the polar catheter and map the more clear location of a bypass tract relatively easily. And another question is this patient had reduced ejection fraction, right?
Yes.
So does he recover the LV dysfunction completely or still has?
Not yet because last ablation was end of the October, so I wanted to check after three months after ablation. It was supposed in the end of the January, so not yet check about the improvements.
So you mentioned about the potential desynchrony-induced cardiomyopathy or tachycardiomyopathy, but unless the patient recover the LV function completely, you need to evaluate the potential associated cardiomyopathy in this patient.
Yes, yes.
And
Thank you for.
nowadays their CSP, conduction system pacing is very popular in worldwide. So there is several desynchrony index and another modern technology to define the degree of desynchrony. Not only degree of the desynchrony, but also we can estimate the causal of desynchrony related to conduction pattern. So I think we need to study about that. And can you see there? I still don't understand exactly. You showed their RV septal pacing and RV free wall pacing, and compare to estimate the location of both.
No, this is not pacing, but we just move the catheter to the RV side, freeware side, and septal side.
And what did you want to say? I didn't understand exactly.
So when we moved the RV catheter to relatively in the freeware side, signal shows a little bit earlier than the his. And then when we put the position of the RV catheter relatively septal side, and then it is relatively on time with the his. That means some bypass track is relatively the freeware side, and then early conduction to the RV catheter.
So you draw the line in both
Yes.
left ram.
Yes.
Which one is the reference side? Because it was not the draw from the beginning of a QRS and set. What is the
Right.
reference point?
The deflection from the RV distal.
RV distal. I see. Okay, now I understand. So by changing the location of RV catheter, you estimate the location of accessory pathway.
Yes,
Am I
yes.
right?
Not me, Dr. Huang.
I see. That's interesting method. And actually, during my sabbatical, I dissected the cadaver heart, and there's a huge variation of thickness of tricuspid annulus. In some patients, it is very difficult to maintain the stable catheter position. But if it is anteroseptal bypass tract, usually I try to map the V insertion site of accessory pathway, because the V insertion of anteroseptal bypass tract is a little away from the his bundle rather than the A insertion of bypass tract. But if the thickness of a tricuspid annulus is very thick, in those patients, it is very difficult to maintain the stable catheter position. Dr. Has many experience of anteroseptal bypass tract. Do you have any technique to better and safer?
Not so many. I think you guess the accessory pathway location from surface ECG. So I recommend you place the catheter where you suspect about pathway location. Yeah, Professor Hinan Park said recommended also. You put the duodenal catheter around the his or anteroseptal or right anterior annulus area. You can map and you manipulate the duodenal catheter for better visualization and A and B signal. Put the duodenal catheter in just on the tricuspid annulus, and you need to check if you need to confirm this is A signal and B signal by VA block and AV block signal. And when it comes to Parisian accessory pathway, you can approach from SVC approach. I mean jugular, from the jugular vein. You put the catheter into the RV deep inside, and then you make a J shape, and then hook the under the tricuspid valve and B-flat. Then you can ablate the accessory pathway more V side. Then the other approach is sinus valsalva approach. You can ablate the accessory pathway from the sinus valsalva.
Sinus valsalva? Anteroseptal?
Yes.
Midseptal?
Midseptal. Yeah, and second choice is cryo. However, cryo ablation is not available in Cambodia. Also limitedly available in Korea. And I think the detailed map and find out the accessory pathway potential and in detail, the sniper's approach is best way. And the one thing, the accessory pathway potential should be on time or before the delta wave onset. However, at first your ablation, your your potential accelerated suspicious accelerated potential is not before the delta wave, so that is not accelerated potential.
Yes, yes.
Okay, Dr. O's last slide, the key question was if it is really difficult right side accessory pathway. So is it deep accessory pathway, oblique accessory pathway? How can we do it? Stubborn accessory pathway, how do you ablate it?
For mapping the oblique pathway, we can change the V pacing or A pacing. Propagation of way of the propagation by changing, we can map the oblique pathway and we can let it a little bit longer between A and B potential by changing the propagation way. And for deep accessory pathway, I don't have a clear answer.
Do you have any experience for 3D mapping?
For the redo cases.
Is it helpful?
Not much helpful actually.
Not much helpful.
Same difficulty.
Okay. I have one experience with epicardial ablation in the right side bypass tract. And the Orange Eggman recommend to map the right side coronary artery mapping with microcatheter, but I didn't do that. But I failed. Like this case, we delivered too much energy, but luckily that patient had free wall accessory pathway, but still we cannot cut the right side free wall accessory pathway, so we entered the epicardial map at the redo procedure, and high density 3D map was quite helpful, so we could ablate it by single burn, but definitely we need to check the right coronary angiogram and compare the ablation catheter position and the coronary artery position. Any other comments or questions from fellows? Kofi, you have some questions. You may have.
No, I don't.
Okay. Okay, if there is no more question, thank you so much, Dr. O and Dr. Chia, and
Thank you.
it was very valuable sharing of experience, and have a nice weekend. Oh, Dr. Chia, so do you have some last comment?
No, I think it's a great presentation, great discussion. I've learned a lot myself. Thank you so much for the opportunity to join your conference.
Okay, thank you very much. Have a nice weekend. Bye.
Thank you
Thank
very
you very
much.
much.
Okay, good day.
감사합니다.
Bye. Bye.
오늘 황 선생님이 있을 때가
네.
네.